So now we're going to move into our musculoskeletal and our integumentary portion of the review. So when we talk about bone remodeling and repair, if we have any sort of fracture or damage to the bone, we have a few steps. I included this diagram from your textbook. I think it's really helpful. But essentially, we have this formation of our hematoma, which is going to end up forming a clot to kind of help keep everything together and promote healing. So after this clot forms, we're going to have this callus that forms as well. And the callus is more of our structural protective network that's going to help promote growth and healing, and it kind of helps stabilize everything. Essentially, this cartilage turns into that bony callus. Osteoblasts do their thing. They give us new bone cells, etc. Now we have a really, really hard callus, which is good. Our bones are supposed to be hard. And then at the end of all of this, we have bone remodeling. Osteoclasts end up coming in and kind of breaking things down just to help kind of shave it, remodel it, etc. When we talk about fracture classifications, there's many different ways we can classify fractures. I included all the different types of fractures here. I would just know that more of our complete fracture, we have a break in several pieces. If we have our green stick fracture, it's not necessarily a complete break. It's not going to break all the way through. Pathological fractures, think osteoporosis. Their bones are a lot more brittle than ours, and they're at risk for fractures. I would just kind of review what some of these fractures do look like, and then a couple more different ways we can classify. Is it closed, open, complete, spiral, etc.? So when we talk about injuries, our most common injuries you'll see are your sprains and your strains. So when we think strains, see that T in strain, think tendon, okay? There's a tear injury to a tendon. What do tendons do? They help attach muscle to bone. Our sprain, on the other hand, this is a ligament. When we think ligament, think bone to bone. An avulsion is probably the worst. This is a complete separation of a tendon or ligament for its bony attachment to our site. A very common avulsion injury is on the fingers, especially basketball players. If they were wearing a ring, that could get caught in the net. Those are avulsion injuries. I didn't include a photo, but if you wish to look it up, you can. Rhabdomyolysis. So this is a really big concern, especially for our kidneys, because damaged tissue contents end up leaking into the bloodstream. These damaged tissue contents are very, very toxic. So if any patients had severe muscle trauma, prolonged immobility, they're at risk for rhabdomyolysis or rhabdo. The big issue with rhabdo is, well, yes, we do have this damaged tissue. We're really concerned about our renal failure. So that's going to be our main complication of rhabdomyolysis. These patients will present with myalgia, that muscle ache, muscle tenderness, and crush syndrome. Another thing we need to look out for rhabdomyolysis is compartment syndrome. If we have any sort of damaged tissue, you'll actually see this increase in pressure within the muscle compartment. You'll also have very, very dark urine. This is because there's actually red blood cells and protein in the urine. With compartment syndrome, you'll have numbness, tingling, pain. If you go to palpate for a pulse, you're going to feel a decreased pulse distal to wherever the compartment syndrome is occurring. I don't know if any of you guys watch Grey's Anatomy, but there is an episode where Owen Hunt, I believe it was Owen Hunt, had to treat a teenage football player with compartment syndrome. So I'm pretty sure you can look that up, Grey's Anatomy. Compartment syndrome, and they do a really good job of explaining it too and kind of putting it all together. Osteoporosis. This is our silent chronic disease of cellular regulation. Essentially, old bone gets reabsorbed faster than what's being produced. We have this there is no balance, so we're having a really big issue. These patients are at insane risk for fractures, and because this bone is poorly mineralized, they're going to have thin, fragile bones. Usually it's linked to females after menopause as well. You might see some dorsal kyphosis, cervical lordosis, etc. in these patients as well. Also, patients that are on that have chronic alcohol use, they're chronic smokers, or even steroid use puts us at risk for osteoporosis. Osteomalacia, it sounds similar to osteoporosis, but it is pretty different. Essentially, with osteomalacia, we're having a really difficult time absorbing calcium due to a lack of vitamin D. If we don't have vitamin D, we cannot absorb calcium. What does calcium do? It helps us mineralize our bones. So if we can't mineralize and calcificate our bones, they're going to be weak and soft. These patients have a lot of pain, bone fractures, etc. Also very common in our chronic kidney disease patients. So, osteoarthritis versus rheumatoid arthritis. They are both forms of arthritis, but they are very, very different. So when we talk about osteoarthritis, I want you guys to think wear and tear, normal wear and tear. Athletes, etc. With osteoarthritis, it's not an inflammatory issue. Essentially, what's happening is that this cartilage just kind of gets worn down, bone spurs begin to form, etc. But usually you're going to have this localized arthritis and asymmetrical. What do I mean by asymmetrical? Let's say I'm a right-handed painter and I'm using my hands a lot. Probably going to have a lot of arthritis, osteoarthritis in my right hand, but if I look at my left hand, I'm not going to have that arthritis there. That's what I mean by asymmetrical. Or rheumatoid arthritis, this is an inflammatory autoimmune disease. Therefore, I'm going to have what is called symmetrical arthritis. So I'm going to have arthritis in both my left hand and my right hand. This is because it's not due to normal wear and tear. There's actually a systemic inflammatory process happening in my body, so it's damaging a lot of the joints in my body. Again, autoantibodies attack our rheumatoid factor. When we talk about gout, this is essentially the buildup of uric acid in the blood. And where will this uric acid deposit? It loves to deposit in joints. Where's the favorite joint of choice? Our greater toe. So essentially, the uric acid builds up and it causes crystals to form. What happens when the crystals form? Massive inflammation. This inflammation causes pain, heat, tenderness, etc. It's almost always linked to our diet. So have you guys learned about certain foods that are high in uric acid? That's going to be kind of what we're going to want to educate our patient on, is avoiding foods high in our uric acid, like aged meats, etc. When we talk about pediatric issues, while we do see lots of sprains, strains, fractures in our pediatric population, some of the more common issues we also do see is our DDH, developmental dysplasia of the hip. So essentially, our hip is a ball and socket joint. But what's happening with this is there's some sort of issue with our hip joint not being able to accept the femur. So what are some risk factors? Breech pregnancy in females. What is breech pregnancy? It's when the baby comes feet first. So if the physician ends up having to kind of tug on the feet and move the baby around, they're at increased risk for this. Females also simply because our pelvis and our hips are just different. They're made to kind of be a little bit more flexible for when we get pregnant. So just kind of think that in mind. These patients are going to have really hard time abducting their hip, positive Bortoli sign and positive Barlow sign. There are videos you can look up on that where they actually do show the physician manipulating the hips and showing those tests. Osteogenesis imperfecta, this is our brittle bone disease. So our bones are porous. Fortunately, this is a genetic disorder. So unlike osteoporosis, it is a genetic issue. It's not necessarily because of diet, immobility, etc. But essentially, these patients are having a hard time creating collagen. Collagen kind of helps us make our bones a lot more solid. So major complications: osteopenia, brittle bones, fragile bones. Specifically, they're going to have very, very deformed teeth, hearing loss, because we have lots of collagen cartilage in the ear, bones in the ear, and blue sclera is very common in these patients as well, so I included that photo. Talk about Duchenne muscular dystrophy. We're talking about an X-linked recessive disorder. When you think muscular dystrophy, this is a skeletal muscle degeneration. So there's wasting of the muscles. Okay. It is not a neuro issue. It's simply an issue with their muscles. So with Duchenne, this is X-linked recessive. So again, it's mainly going to occur in males because males only have one X chromosome. So just kind of keep that in mind. Similar to how males are more at risk for hemophilia, if it's an X-linked trait, it's almost always going to occur more commonly in males. Because females, we have two X's, we can balance it out, but with males, they can't. So what's happening is that they're having a degeneration of skeletal muscle fibers. As these fibers begin to degenerate, they're going to have lots of weakness and wasting. So with these kiddos, they're going to have slow motor development. Sitting and standing is probably going to be delayed. Usually by 3 years old, kiddos should be kind of running around, running into things, climbing things, etc. They might still be crawling because just their muscles are so weak. These child are going to be clumsy, falling frequently, and just have difficult time doing normal toddler things. So now we're going to talk about our integumentary system. So I included this photo to help you guys classify skin lesions. We have our macules, papules, plaques, wheals, vesicle, excoriations, etc. So when we think excoriation, it's more like erosion, more of your scratching, if you will. Our vesicles is filled with fluid, okay? Usually clear fluid, whereas our papules, it's not necessarily filled with that clear fluid. So just kind of keep that in mind. Our macules, those are like our normal freckles. When we talk about pressure ulcers, these are a really, really big issue in the hospital because our patients are bedbound, especially in the ICU, or simply patients aren't up walking as much when they're in the hospital. So it's really important to learn how to stage our pressure ulcers. So if we have a pressure ulcer that's stage 1, it's a non-blanchable erythema of intact skin. So they're going to have redness. When we talk about blanchable, if I push on my skin, it's going to turn white and then it's going to go back to its normal color. But if it's non-blanchable, I'm not going to see that color change. Okay. Stage 2 pressure ulcer, this is partial thickness loss into the dermis. So it's going into the dermis, but it's just more partial loss. So you might see, again, that redness. You might see a little bit of skin erosion, but it's not full thickness. Stage 3 is more of our full thickness that actually goes into the subcutaneous tissue and can extend a lot more. When we talk about stage 4, this is full thickness, but now we can see muscle, bone, or other structures, and there'll be a lot of tunneling. When you think tunneling, think if I just kind of literally took like a scoop out. That's what tunneling is. And when we have unstageable, whenever you think unstageable, it simply means I cannot determine what this is. What are some situations that make this occur? If my ulcer is covered in pus, eschar, or both, and I simply can't see how deep it's going, what areas are lost, that's what we classify as unstageable. So if there's so much like black eschar and I can't tell what I'm looking at, that's what we would call unstageable. A couple other skin issues: allergic contact dermatitis. This is a T-cell hypersensitivity reaction. Usually does require a primary exposure, but this is our delayed hypersensitivity. So essentially, it causes inflammation, redness, papules, plaques, etc. But it does take a little bit of time to kind of build up this allergic reaction. This is more of our common allergic reactions. Whereas irritant contact dermatitis, not all of us have allergies to Tide or to rubbing alcohol. Those simply just have lots of toxins, lots of chemicals that are very, very harsh. So these are harsh irritants, acids. Our skin doesn't burn if we spill acid on us because we're allergic to acid. It's just simply because this chemical is so strong. So that's when we have our irritant contact dermatitis. Just a really strong irritating chemical, usually over time, constant wear and tear, damages the skin, or if it's harsh enough, like acid. And this is non-specific inflammation, meaning it's not tailored to an immune response. Psoriasis is another issue of the skin. Essentially, what's happening is they have scaly lesions developing over their skin, scalp, nails, just because there's a lot of mitosis happening in the basal layer. So we're having this overproduction of more of our callous, scaly skin. And it ends up causing our thickening, skin thickening as well. Talk about skin infections. Most of our infections are going to be either bacterial or fungal. I included lots of examples of bacterial infections. Specifically, I would review impetigo. This is very, very common in our kids. We'll get the impetigo rash, etc. And at any point, if you're in the clinical setting and you've cared for a patient that has Staph aureus or MRSA, they're usually on contact precautions because we don't want to get an infection. Our fungal infections, you'll usually see them classified with tinea. Tinea just means mycosis. Mycosis are part of our fungus. So we classify it based on where it's happening. For example, tinea capitis is happening on the scalp, and we just kind of go down the line. Specifically, our candidiasis, especially of the tongue, is usually related to immunocompromised individuals. Talk about Lyme disease. This occurs when you get bit by a tick that's been infected with Borrelia burgdorferi. It causes a multi-system inflammatory disease, but essentially when we're talking about the skin in this first stage of Lyme disease, you'll see this bullseye rash, okay? You'll also see fever, etc. Afterwards, you'll end up kind of seeing the patient go, if it's left untreated, into the disseminated phase where they're just really tired, achy, have a little bit of fine motor movement problems, and then if it's left untreated for years, we have lots more complications. Scleroderma, this is an abnormal hardening of the tissue related to too much collagen being produced. But again, it's not limited to just the skin. Our organs have tissue. So while thickening of the skin might be uncomfortable, it's not necessarily life-threatening in the same way as if we have stiffening of our organs. Leads my organs to not function as well, which can lead to organ failure. When we have localized, this usually only affects the skin. Our issue is when it's systemic, because this can now affect our connective tissue and our internal organs. Again, we have lots of different complications, but I would just kind of keep in mind localized versus systemic. When classifying different types of skin cancer, one of the most common ones is our basal cell carcinoma. These are usually more of your safer forms of cancer. They grow pretty slowly and they're rarely going to spread. The photo in the top corner, that's your basal cell carcinoma. Our squamous cell, this almost is always limited just to the lip. It can grow anywhere else, but usually you'll see it present on the lip. The issue with this is it can grow deeper into the layers. Our malignant melanoma, really we're concerned about spreading, and it can usually spread pretty quickly. Our Kaposi sarcoma is very, very rare. You'll almost always see it specifically in immunocompromised individuals, such as patients who have AIDS, our patients on immunosuppressant therapies, patients with chronic disease, etc. But this is really life-threatening. And if we're ever classifying any sort of skin lesion, I just really want to reinforce the A, B, C, D. It's kind of your like alarm of, is this normal? So our asymmetry, border irregularity, color variation, diameter larger than 6 millimeters. Is it elevating above the skin? Is it evolving? Is it changing? Those are all how we're going to classify maybe a potentially cancerous skin lesion. So just review that. Up next, we have burns. Usually our first degree burn, this is our traditional sunburn. It's pretty superficial. When we talk about our second degree burn, this is a superficial partial thickness. So while it won't spread all the way down to the muscles and the surrounding structures, it might go through a few layers of the skin. Our main issue with a lot of our burns, specifically our second, third, and fourth degree, is that these patients will have edema, hypovolemia, and hypotension because of the massive dehydration, fluid electrolyte loss occurring. Our third degree, this is when it's deep partial thickness. You'll usually be pretty mottled as well, and it does take a long time to heal. And finally, our fourth degree burn, this is full thickness. You'll actually see tendons, bones, etc. Usually these do not heal. You'll need skin grafting done for these patients. And up next, we have eczema or atopic dermatitis. Usually there's a genetic link to it. Usually patients will start presenting with eczema at about 5 years old, and it just kind of stays with them for life. One thing about eczema is that kids with eczema are also prone to asthma and allergies. There's just a link between the two. But usually you'll see this redness, itching, etc. We really want to teach the kids and the families avoid rubbing and avoid scratching, because this is what's actually going to cause those skin changes, etc. Usually these lesions are limited to the face, scalp, trunk, arms, and legs. Next, we have rubeola versus roseola. Both are different types of infections. When we talk about our rubeola, these are our red measles. It's a viral infection that's extremely communicable. Usually they'll have this maculopapular rash over the head, and then it ends up spreading to the trunk and all over the place. Also in their mouth, they will have these white spots. So if a pediatric patient comes into the ER, parent brings in their kid and they have this really big rash all over their body, and you see these white spots in their mouth, I want you guys to think of rubeola. When you think the color ruby, think red. That's what this red maculopapular rash is going to be. Roseola, on the other hand, this is an HSV 6 or 7 infection. Usually, again, they're going to present with more of a swollen erythematous rash that lasts about 24 hours. Usually this one's going to be kind of limited to that trunk as well. You'll see the patient spike a really high fever, but then it will kind of go down. And as that fever actually goes down, that's when we see that rash. So with our roseola, they're going to have a fever that's going to precede more of a trunk rash, if that makes sense. So that is all I have for you guys. I hope this was informative and helpful. Does anyone have any questions? Does anyone want to go over something again? Go back to some slides, anything like that? You're welcome.